ladies and gentlemen, doctors, professors, and my esteemed colleagues. My name is Teoh, and I'm one of the consultant breast oncoplastic surgeon currently working in University Malaya Medical Center in KL. So we are happy to have all of you here today for our 4th episodes of the Greater Petaling City Wide Capacity Strengthening of the MDT Management in Breast Cancer. So just a recap on our last 3 episodes, which some of you may actually missed out. We are actually following the objectives of the Global Breast Cancer Initiative Implementation Framework, where we talk about the 3 pillars. All right, so the first one we managed to discuss on the early detection, followed by timely diagnostics, okay, both imaging as well as the pathology report. And today we are glad to have an array of panelists as well as experts from overseas to talk about the comprehensive breast cancer management and mainly focusing on the treatment interval. So without further ado, I would like to start off our program for tonight by inviting none other than our Professor Dr. Noor Aisha Muhammad Taib, who is currently the head in the Cancer Research Institute and the lead person in the City Cancer Challenge since 2019. And a special interest includes quality improvement project as well as genetic screening. And she is also the primary investigator in the Robong project, which is our reducing barriers in cancer early diagnosis among the B40 group. So the floor is yours, and Prof. Aisha will deliver a short introduction on the Greater Petaling City Cancer Challenge. Over to you, Prof.
Thank you very much, Dr. Teoh. So I'd like to really maybe recap what we have been doing over the last 2 years, I think, with this project. This project is called the Greater Petaling Citywide Capacity Strengthening of MDTs or Team Management in Breast Cancer. So really, this is one of the action plans that is funded by the City Cancer Foundation. Okay. So maybe we'll just talk a little bit about what the project is about and what the outputs were from the project and what our sustainability plans are. So a little bit about City Cancer Foundation. It was launched by the Union for International Cancer Control in 2017 at the World Economic Forum in Davos. And in January 2019, it is now a standalone Swiss foundation based in Geneva. So what CCAN does is it supports cities around the world as they work to improve access to equitable quality cancer care. So Greater Petaling is one of the 13 cities around the world. We are actually the number 9 city, looking into how we can improve the quality of cancer care and giving access to equitable care. So this project is really aims to strengthen the multidisciplinary team care and standardization of care of breast cancer in the Greater Petaling City by November 2022. So CCAN proposes capacity building activities that will introduce and disseminate a multidisciplinary and evidence-based clinical decision-making approach for breast cancer in the city. So in the year 2020, CCAN received an award from the Islamic Development Bank and International Atomic Energy Agency to run this program that took place between December 2021 to November 2022, and a program that was sustained from this project from December last year to this year. So I'd like to introduce our project team members. They may actually be here today, and if you are here, please put on your videos. We have Ms. Anita Bagawi, the head of our National Breast Cancer CPG Development Team. She's the consultant breast endocrine surgeon in Hospital Putrajaya Ministry of Health. And Dr. Izuna Mudla from the Malaysian Health Technology Assessment Section. Both are co-leads in this project. And then we have representation from other professional bodies, from the College of Radiology, Dr. Vijaya Lakshmi, from anatomical pathology, Dr. Muhammad Rafi'i, Ms. Patricia Gomez, who is also a consultant breast surgeon, Dr. Vaishnavi Jayasingham, consultant oncologist from HKL and Subang Jaya Medical Center. We have Professor Lam Chilong and Dr. Lim Shusian, consultant palliative care physicians. And we have Matron Nur Nadia Renu Abdullah. So this multidisciplinary team of project team members were working hard to create a few key outputs. So the first one was documentation and dissemination of the best practices in implementing MDT for breast cancer. It's a document that has been endorsed by the Ministry of Health Malaysia and will soon be on our website in the City Cancer Challenge website. We have capacity development of the MDT care practice and standardization by conducting the ESCO CCAN MDT Cancer Management course, MCMC, last year. And we have conducted scientific visits to Tata Memorial Center early this year. And as we mentioned, we are now currently at number 4 of the ECHO program, where we are focusing on education on how we can effectively use the MDT platform. So this is the scientific visit to Memorial Cancer Center in February, where I think I also met Dr. Rima at the cafeteria. We had delicious vegetarian meals sponsored by the hospital. It was really lovely. We managed to meet all the different disciplines that manage cancer care equitably in a very low resource setting, but also very high quality care that was given to the patients. So what this project is about is really to identify hub hospitals and spoke hospitals. This project that we're doing today, the ECHO. How we plan to do the sustainability plan is by 4 phases. The first phase is by building networks between single specialty hospitals and tertiary multidisciplinary public hospitals and private hospitals, and provide comprehensive cancer care through ECHO educational MDTs is what we're doing today. Phase 2 is really building these networks through creating structural referral networks and providing service MDTs. And we hope that we can do this next year. And phase 3, building quality audits and indicators for multidisciplinary quality cancer care, as well as in phase 4 in 2025, where we will start hopefully being able to do quality audits for the city. So the project involves several hospitals in the public and private hospitals. So we have about 25 hospitals that is currently involved in the City Cancer Challenge needs assessment. And we also have private hospitals that are involved. So our sustainability partners for this project is really Ministry of Health, where we have a clinical practice guideline. And of course, the facilities for B40 remain actually in the Ministry of Health. And then Academy of Medicine, and then we are using this ECHO platform from the University of Malaya MOU with the University of New Mexico. And then we have other institutions as well, the private institution, and our global partners with CCAN, Tata Memorial Cancer Center is actually one of them, ESCO, as well as Breast Surgery International. We hope to work with the quality indicators with the Malaysian Society for Quality Health. So this is actually my last slide. We are now on the 29th of May, and we have been engaging with 4 hub and 4 spoke hospitals over the last few months. And we hope that this platform will provide more information and education so that we can improve the quality of cancer care in our city. So you can contact either me or Miss Anita if you need further information. So with that, thank you. I'll stop here.
Thank you very much, Prof. Aisha, for the great introduction about what our focus is for today. So next up, we have our honored guest. Okay, we have actually Associate Professor Dr. Rima S. Pathak, who is currently the Consultant Radiation Oncologist from the Tata Memorial Center in Mumbai, India, from 2017 until now, I suppose. And currently, she's also having her PhD in cancer genetics ever since 2018. And she has an area of expertise in managing breast cancer patients, lung cancer, as well as bone cancer patients. And she's actively involved in various clinical trials and cancer research. So we are honored to have her tonight to talk about the timely adjuvant treatments and the impact on breast cancer outcomes. So the floor is over to you, Prof. Rima.
Thank you so much for the kind introduction. I'll just be sharing the slides. Good evening to all of you till then, and I hope I am visible. My slides are visible to you?
Yes, Prof.
And they are in the full screen mode?
Yes.
Yeah. So thank you once again. I think it's an extremely important topic to talk about. That's the timely adjuvant treatment and its impact on breast cancer outcomes, especially looking at what y'all are trying to establish currently in Greater Petaling. So I do not have any conflicts of interest. And diving straight into the topic. So we know for patients who have high-risk breast cancer, their management involves multidisciplinary care. And here I'm just highlighting the three main pillars of breast cancer management. That's surgery, chemotherapy, and radiation therapy. And here you can see for those patients who require all three of them, these are the three major types of sequencing which are commonly used for their treatment. And when we say adjuvant therapies, we mean that after surgery, when the patient undergoes chemotherapy or adjuvant radiation therapy, we'd be talking about how it impacts when there is delays or when it is not managed in a timely manner today. So let's just first quickly look at what are the reasons for this delay. So the reasons for the delay could be financial and social, and these are important delays looking at the lower and middle income countries like ours. Lack of infrastructure and expertise, restricted access to drugs, medical insurance approval, racial minorities, or geographical distance from their house to the hospital. It could be misdiagnosed, or there is fear of therapy. And all of these contribute towards sometimes small but otherwise major delays in instituting regular care. Now, we'll first look at what are the significant factors that cause delay in adjuvant chemotherapy and what is their impact on survival. And we will be looking at three different time points, that is 90 days, 60 days, or 30 days. And these we have selected because contemporary series report on these three timelines. First, we'll look at a very large set of patients, nearly 25,000 patients from the Californian Cancer Registry. This particular registry looked at patients who were stage 1 or 3, 1 to 3, and here it showed that when you had a delay of more than 90 days, even for the full cohort, there was a significant impact on overall survival. As you can see, the hazard of 1.34 over here. And this was especially true for TNBC subgroup when there was a delay of 90 days for instituting chemotherapy with a hazard of 1.53. Here on the left side, you can see a table with differences in different hazards when there was increasing delay from less than 31, which is supposed to be ideal, to up to 60 or more than 60, up to 90 and more than 91 days. And here you can see that significantly and sequentially the hazard continued to increase. Similarly, for HER2 positive patients also, up to 60 days was okay, but beyond 60 days, the hazard started to rise. And for more than 91 days, even for HER2 positive patients, there was a significant detriment in their overall survival. And when you want to see breast cancer specific survival and not just the overall survival, here you can see that again, it shows the same thing, that in TNBC, more than any other molecular subtype, there was a significant detriment in overall survival and breast cancer specific survival. So this particular study, which is a very large study and a contemporary one, shows that especially aggressive histologies are affected by significant delays in instituting chemotherapy, and definitely we should not delay adjuvant chemotherapy by 90 days. Now coming to the next, so coming to the 60-day time point. So the MD Anderson Cancer Center series of 6,000 and over patients, again from stages 1 to 3, showed that when divided between the most ideal, which is less than 30 days versus 31 to 60 days and more than 61 days, there was significant delay. There were significant differences in their different survival endpoints. When we looked at when they divided the subgroup into stages, the stage 2 versus stage 3, they saw that the stage 2 was not affected by overall survival, but the distant metastasis rates were higher. So the hazard of having distant metastasis was higher if the patient had more than 61 days of delay. That means 2 months of delay in instituting adjuvant chemotherapy. But when you came to stage 3, all different survival endpoints were affected, as you can see over here. So not just the distant metastasis-free survival, but locoregional recurrence as well as overall survival were significantly impacted and worse in these patients. coming to again more aggressive histologies and molecular subtypes, it again showed that the TNBC and the HER2, whether or not receiving trastuzumab, their hazard was higher if it was again delayed by 2 months. So therefore, delay in adjuvant chemotherapy affects outcomes, especially of higher stage and biologically aggressive molecular subtypes. And a delay of more than 60 days or 2 months is detrimental to these patients. Looking at chemotherapy delayed by 30 days. So that means, should you start chemotherapy within 30 days or after 30 days is all right? So again, looking at a smaller subgroup of patients of around 2003 from Royal Marsden Hospital, these had essentially stage 1 and 2 patients. But when they are receiving chemotherapy, we know that these are patients with some of the other high-risk histology or high-risk pathology, and a few 3A patients. So here we saw that patients who started chemotherapy beyond 3 weeks, beyond 4 weeks after surgery had absolutely no difference in overall survival or disease-free survival. So the 30-day mark was not important for the overall cohort, but when they looked at a subgroup of patients which were TNBCs, so here they found that TNBCs were more sensitive to even shorter delays as compared to the other molecular subtypes, especially when they were low stage or stage 1 to 2 disease. And therefore, one understands that when we are dealing with biologically aggressive subtypes like TNBCs, even shorter delays can impact their survival. Now, looking at a paper which specifically looked at the differences in molecular subtype and their influence by delay in institution of chemotherapy, and this is from China. This is a relatively contemporary cohort of 1,500 odd patients, and they looked at again the 4-week, 8-week, and more than 8-week time point. And here I would like to draw your attention towards the disease-free survival and the overall survival. And as you can see, with more and more delay in institution of therapy, the outcomes are worse, and these are significantly worse. The ones that had significantly worse outcomes had similar profile, or the factors affecting their outcomes were when T size was more than 2 centimeter, node positive, TNBC is HER2 positive, and more than 8-week delay. All of these factors were associated with poor overall and disease-free survival. And therefore, one would say that specifically aggressive histologies, again, when they looked at, they saw that patients with TNBC and HER2 positive disease did worse as compared to those with luminal A. Even the luminal Bs had a much worse hazard as compared to the luminal A hazard. And therefore, one should be more sensitive towards the molecular subtype as well. And chemotherapy should be initiated within 4 to 8 weeks, especially for these patients. Now, coming to delay in trastuzumab. So many of these series, which date back to beyond 2010, many of them did not give trastuzumab to all their patients. So here, this is a patient. This is again the Shanghai Cancer Center series, where they could split their cohort into 2 different cohorts, where patients received trastuzumab and patients who did not receive trastuzumab. And the bottom line still remains whether or not the patient received trastuzumab. Delay in instituting trastuzumab led to a significant detriment in both the disease-free as well as the overall survival. And when the patients did not receive trastuzumab and received only chemotherapy for HER2 positive disease, it also led to poor distant metastasis-free survival, more as compared to those who received trastuzumab. And therefore, especially if there is a significant delay in instituting therapy like trastuzumab because of either poor access to drugs or something, one should be more sensitive towards at least starting chemotherapy in time for these patients. Now, coming to what should be delivered first, whether it should be radiation therapy or chemotherapy, and this is a question that several times our residents keep asking us, and other specialties keep asking as to what should come first, whether it should be chemotherapy or whether it should be radiation. Sorry. So here I'm just showing that the older series, there was a discrepancy. Here you can see that the older series showed that some of these studies showed that when we gave chemotherapy first, there was a significant detriment in the locoregional endpoints or locoregional recurrence rates. Whereas when we gave radiation first, they showed that there were more distant metastases and worse disease-free survival, and therefore maybe chemotherapy should have been preferred. here, so there is another series which looked at a more contemporary cohort. And I'm talking about a contemporary cohort where patients did receive anthracyclines and taxanes. And here they saw that perhaps giving RT later on did not really impact the locoregional outcome as much as it did impact when chemotherapy was delayed. And this is because anthracycline, taxanes, trastuzumab, and hormonal therapy, all of them contribute sequentially towards locoregional control as well as distant metastasis-free survival. And therefore, one has to understand that endpoint as well. Now, this is another study from China, which looked at whether or not RT versus chemotherapy should be given first. In this particular series, the older series gave radiation first, that is from 2000 to 2007, versus from 2008 onwards, significant number of patients received chemotherapy first. Chemotherapy first was preferred in more aggressive or high-risk patients such as node positive, stage 3, and those with LVE. And delay with chemotherapy first in starting radiation therapy was around 4 to 5 months, whereas the other way around was around 6 to 8 weeks. So here they saw that if chemotherapy was delayed by 14 weeks when radiotherapy was given first, or if chemotherapy was delayed by significant interval, it affected all the distant metastasis-free, disease-free survival as well as overall survival as an important endpoint. And therefore, one would again think that it is important to start chemotherapy in time as compared to radiation therapy before. Now, in another series from NCC China, which is again a contemporary series of a smaller number of patients. So here again, we saw the same thing, surgery to chemotherapy delay or surgery to RT delay when chemotherapy was given first. And here they showed that, again, when you start chemotherapy within 12 weeks, it improved DFS, locoregional control, as well as distant metastasis-free survival. And this was despite the fact that patients who had chemotherapy first were patients who had more aggressive disease. So delaying radiotherapy was still okay in this particular cohort as compared to delaying chemotherapy, even in low-risk disease patients. Now we are talking about delay of radiotherapy after completing all chemotherapy. So this is not while waiting to complete one leg of their therapy. This is actual delay where patient is not receiving any therapy and just simply waiting to start their radiation therapy. Does that have any impact on the survival endpoints? And this particular series in Annals of Surgical Oncology was published recently, which showed that in about 1,000 patients, when they evaluated a delay of more than 12 weeks versus less than 4 weeks after chemotherapy, they saw significantly worse breast cancer specific as well as overall survival in these patients. And when we looked at the factors that affected that were more affected by this particular delay, were hormone receptor positive tumors, node positive, and patients post MRM. Post MRM patients means those patients who have high risk factors and require radiation therapy. And as you can see over here, the delay in radiation therapy also after completing all planned chemotherapy should not be more than 4 weeks. Now, we are talking about delay in starting hormonal therapy. So when we look at hormonal therapy, one would imagine that perhaps delay in starting hormonal therapy may not affect it. But the NCTB data in more than 1.5 lakh patients as seen between 2004 and 2014 in ER or PR positive, HER2 negative disease in stage 1 and 2 essentially patients, they compared patients whose hormonal therapy was delayed by more than 5 months since surgery as compared to those patients where it was delivered before. And here they saw that when compared to the cohort of patients where there was no delay, the patients who had delay were patients with non-private insurance, patients who were treated by community practicing physicians who had more comorbidities or were significantly younger or of Black race. The other factors that caused delay but were not associated with poor survival was breast cancer specific, conserving surgery and receipt of radiation therapy. So while these two factors caused delay, they did not cause overall survival. Now, delay beyond 150 days, as you can see, had a significant impact on overall survival. And the factors at risk were no receipt of chemotherapy. That means patients who did not receive chemotherapy, and stage 1 and stage 2 disease. So here you can see on the right side forest chart that majority of these factors were detrimental towards the delay in hormonal therapy. So therefore, I would like to conclude that post-surgery delay in adjuvant chemotherapy can lead to poor overall survival and disease-free survival, and therefore one must be sensitive towards these endpoints. Delaying in radiation therapy while providing chemotherapy did not affect the outcomes, and therefore should be all right, because chemotherapy also contribute towards locoregional recurrence rates or locoregional control. And delay of more than 12 weeks after in RT after completing chemotherapy led to worse breast cancer specific and overall survival. Outcomes affected specifically in adverse biology disease such as TNBCs, node positive, stage 3, LABCs, etc. And among HER2 positive, whether you provide trastuzumab or you do not. When there's a delay of more than 8 weeks in patients who are receiving trastuzumab, the overall survival is affected, whereas when even chemotherapy is delayed when patients are not receiving trastuzumab, it affects both DFS and overall survival. And a delay of more than 150 days or 5 months in instituting hormonal therapy for hormone receptor positive disease leads to a significant impact on overall survival, especially when not giving chemotherapy and in stage 1 and stage 2 disease. Therefore, the key take-home message should be that treatment delay can offset smaller benefits of adjuvant therapy, and multidisciplinary care and coordination across treating specialties and centers can lead to better overall survival. Thank you.
Thank you very much, Prof. Rima, for the enlightening talks. So actually, we are all rushing against time. So time is very essential in our treatment, and it is for the benefit of our patients. So when we talk about that, I think today's topic on treatment interval will best describe how do we catch or how do we rush for this time interval. So for the next agenda, we will have a very great case to be discussed, and we have a group of panelists who are very senior, and among them we have Dr. Miss Anita Bagavi and Dr. Miss Sadhana Mahamad. Both are consultant breast and endocrine surgeon from Hospital Putrajaya, which serve as a hub hospital. And today's presentation will be by the Spoke Hospital, which is from Hospital Kajang. So besides that, we do have panelists from the National Institute, Cancer Institute, or IKN, Dr. Rizma Zaid, our oncologist. And we have Dr. Navarasi S. Gopal, who is our breast pathologist from Hospital Putrajaya, as well as we have a consultant radiologist also from Hospital Putrajaya, Dr. Mezlina Zakaria. And the case presentation will be presented by Dr. Miss Rubiah Muhammad Dayaon, who is a general surgeon from Hospital Kajang. And I did a little research on how far is Kajang away from Putrajaya. It takes about 19 kilometers and 24 minutes drive, right, by car, without jam. All right, so over to you, Miss Rubiah, for your case.
Hello, good evening, everyone. I'm Miss Rubiah from General Surgeon Hospital Kajang. So I'm sharing the slides now. Can everybody see the slides?
Yes.
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 But, now full screen.
So this is a real case that managed by us in Hospital Kajang, co-managed by Oncology IKN. So I hope this case is suitable in our topic for our topic today. There is some pitfall in the management and some good things point that we can learn from this case. So I shared this case to everybody. Okay. So this is the front door of our hospital. It's just next to our main highway. Near to the main highway. Okay, so this case actually came to us started April 2022 last year. She's a 45 years old Indonesian lady. complaining of gradually enlarging left breast lump for the past 6 months. She had a risk factor of a prolonged estrogen exposure where she had menarche at 9 years old and history of taking combined OCD for the past 10 years. She had a biological sister who had a breast disease, which she unsure whether it was a malignant or benign. Clinically, upon examination on April, she has quite a big breast, cup D. There's a lump, palpable, mobile 3 times 2 centimeter at the outer quadrant, and there's no skin or nipple changes at that time, and there's no palpable axillary lymph node at that time. So I leave the floor to the, should I proceed the presentation, or we should pause for any incoming comment or discussion?
Yeah, I think what we can do is we will pause in between.
Okay.
Yes, any questions by the panelists, we can always stop and discuss.
Okay, at this point, I would say the case profile is a bit unique for our Kajang population. We do have cases from foreigner, refugee, and sometimes we do have cases from prisoner. So as we know, these foreigner, they are coming from slightly, relatively low economic status, and their educational status also. Sometimes we do have some, we call it difficulty to engage their understanding of the seriousness, the gravity of the problem that they had. And so in this case, what I can pick up, based on the risk factor and the nature of the lump, there is an urgency to obtain a diagnosis in a timely manner. If now any additional comments, I will just proceed. So since this is a foreigner, so we are anticipating issues for them, for this lady to adhere to our follow-up and management, probably because of the cost, the distance to the hospital, the multiple appointment that she can, engage to our subsequent appointment is one question that we always prepare in back of our mind. So anyway, because of the clinically suspicious lump, we enrolled this case into our pink ribbon.
I think Miss Sadhana has something to say.
Yeah, I just want to ask about. I want to ask about how about the payment for the foreigner and the refugee and those who didn't have a proper documentation to get treatment in our hospital, in Kementerian Hospital, government hospital in Malaysia.
All right. So I did look up with our Hasil department. For a simple ultrasound, they need to pay around 140 ringgit during the first visit. So that's a minimum. So mammogram, unfortunately, I can't find the rate, but from our experience, they need to prepare around 400 to 800 for the imaging. For the surgery, the rate for the mastectomy, for the breast surgery, the ranges between 1,002 up to 2,003. These are from our hospital rate lah. I'm not sure from in Putrajaya or in IKN lah.
So that is comparing to the local, comparing to the payment to the local, how much does it increase? Is it?
All right, for our local specialist clinic is 5 ringgit registration. For pensioner, for government is free or just 1 ringgit. So
it's about double? Is that double or triple from the local? Is it? Am I right?
Yes.
Yes, and then if the patient didn't have any proper documentation, do we accept in our hospital?
All right. Okay. For patient who had no documentation, we had a list of those critically ill case. We call it we outweigh the deposit for the admission lah. For the clinics, so far we absorb at least to get the crucial minimum effective treatment or minimum basic investigation that we can achieve the diagnosis. So they have to prepare that amount of payment at least.
Yeah. So I think this emphasizes the point that Prof. Rima brought up, that financial constraints could be one of the reason where the diagnosis is a bit delayed, right? And also the treatment pathway. Okay, so knowing that foreigners always get a little bit more extra to pay, right? In Malaysia setting, I think I'm sure that overseas you have to pay extra money for that as well. As a foreigner. Okay, shall we continue first, and we shall see. Yeah, any other problems? Yeah.
Okay, so we enroll this case into our pink ribbon clinic pathway, which is we engage our radiology department and also pathology in Hospital Sadar, because we don't have in-house histopathologists. So we send our biopsy to Hospital Sadar. So we able to engage these three departments so that we can achieve a diagnosis and imaging diagnosis and pathology diagnosis by 2 weeks. So we enroll this patient for urgent FNAC and TrueCut biopsy on the day of she presented on April, and we had a mammogram appointment set up for her, and we gave an appointment on the 10th of May to review the results of imaging and biopsy. So all are done. So I'm just sharing, this is our flow of a pink ribbon clinic. At end of the day, end of the flow, we want to get the diagnosis by 2 weeks. And so far, we had a good compliance, good feedback from the pathologist as well. So this is a
I would just
mammogram.
like to stop you there for a while, Ms. Rubiah. Just back to your previous slide, you mentioned that this patient was sent for FNAC and as well as TrueCut biopsy. Maybe from the point of the pathologist, what do you think of the choices of biopsy? Would it differ, or would it be actually helpful to do both? Yes.
Can I? Okay. Basically, I think in this era, TrueCut biopsy is enough to diagnose the cancer. If it, FNAC, it is not widely used in all parts of the world. So FNAC, it is not, if even you don't do, it's okay. Now we need TrueCut biopsy, especially core biopsy, so that we can proceed with the hormone receptor status. So that's my point of view. So in this case, I would also want to ask the presenter, the FNAC and TrueCut biopsy was done under guided or blind method?
Freehand.
Pardon?
Freehand. Yes.
Okay. So just want to emphasize in most of the well-developed countries, or even in Putrajaya now, we are going towards a guided biopsy so that we can get the sample in the first time itself. Most of the time we can get the diagnostic tissue. So we can, in this setting, we can actually minimize the time of diagnosis, because the sample done by the radiologist most of the time is accurate.
But
so
also,
it's less likely to be repeated in the okay.
Yeah, sometimes we do have consideration in obtaining that slot for the biopsy.
Understood.
Unless maybe in a setting like Putrajaya, they do have their own ultrasound machine in the clinic, that would be the best management, I suppose. But I think Kajang, I'm not so sure.
Okay,
Alright.
in Kajang, for ultrasound guided biopsy, we do have the service ultrasound guided and slow tactic biopsy, which is done by our general radiologist. We don't have intervention radiologist, but the slot is only Fridays afternoon, which is previously open only for 2 patients. Only recently they open up it up to 5 patients. So waiting time would be up to 3 weeks, depending on the cases, which is because this slot meaning also for thyroid, also for any retroperitoneal mass or whatever masses that require imaging guided biopsy. So it's sharing slot.
Okay, thank you.
So I just have a point to make. While one might think that it is important to do a guided biopsy, for most palpable lumps, if the mammo is fairly clear, one should be able to do a freehand biopsy. So if you are well trained and if you take at least about 8 cores, so 8 cores is what our standard is. If we take 8 cores from different parts of the tumor, we should be all right. Especially given the fact that you have significant delays just to get an appointment for a guided biopsy. So maybe triage your cases in such a manner where the lumps are not very well palpable, or they're vague, or not very well visible on the mammogram. Those can be triaged for image guided biopsies rather than each and every patient. So the Western world may still be okay with that kind of practice, but again, coming back to our current practice and current scenario of infrastructure and healthcare, one needs to be sensitive towards all of those points as well.
Yeah. Yep. So I think the imaging was given a date on the 10th of May, and that there was like a week or two after the first presentation date.
Yes.
Ms. Ruby?
Yes,
Okay.
yes.
Right.
It's within the 2 weeks.
Okay. Right. We shall carry on first.
Okay, so this is the mammogram. Okay, there's the lesion is clearly showed here. So on the 10th of May, from documentation, now the lump slightly bigger from the previous review is measured as estimated 4 times 3 centimeter, no skin or nipple changes, and mammogram was reported as speculated. This is mammogram and ultrasound. I just combined the impression, high density mass seen at upper outer quadrant with a sub-centimeter axillary lymph node and preserved fatty hilum. So it's suspicious of malignancy BRAF 5. So as expected, the FNAC turned back as inadequate, and the true cut biopsy also picked up only mild usual ductal hyperplasia. So at this moment, radiologically is support the clinical suspicion. However, the pathological diagnosis is not clear. So again, we are still at the level of diagnostic issue. So we are discussing what's the next approach with the patients and husband. We lay out the option whether to repeat the biopsy. Perhaps this time we use imaging guided biopsy, or we are discussing the option of needle biopsy versus diagnostic excision of the lump. Okay, any comments so far?
Can I ask a question? Ms. Rubiah, do you do FNAC and core biopsy on all patients, or just certain patients you would choose?
Certain
or you're
patient.
doing both?
Certain patient.
Okay. I think FNAC, as mentioned before by Dr. Navarasi, we don't really use it, right? Anita, I think what sort of cases would you use FNAC, Anita?
I am a person more towards true cut biopsy, but if it is a very small lesion, sometimes depends on your facilities. If it is too small and difficult to engage a bigger needle, then my radiologists, they will do a FNAC. But if you have these facilities, for example, your stereotactic vacuum assisted procedures, then that would be good. Yeah. But I do prefer true cut, and it is better yield and more information that the pathologist would be able to give us.
Yeah, isn't it the ERP?
I think we never practice sending patient for FNAC anymore. Yeah.
I think that's fair. I think maybe for very benign looking lumps that you don't want to do anything about.
Yeah,
like very
yes,
young.
okay. Yeah, that's some
Those
exclusion
kind
there.
of cases you can do FNAC.
Yeah.
Okay, I
Even
think
sorry,
that was
just even in our latest CPG guideline in the management of breast cancer, there's a part where we recommended a true cut biopsy rather than FNAC, be it whether it's a freehand or an ultrasound guidance.
Yeah.
And
I think in our setup also, FNACs are usually reserved for nodes. Even in recurrent setting, we don't use FNAs. We try and get a biopsy because again, it will give us if there is any change or transformation in the ERPR or HER2 status of that individual.
I think the only place where we would actually offer FNAC is if you've got a complex cyst with a mass within it. Then you put the needle in to get all the fluid and send it for cytology, and then actually co-biopsy the solid part of that cyst with an ultrasound guided biopsy. We've, especially in the private sector, we've all moved away from FNAC completely, except in the situation that I mentioned, and it is always guided biopsy. In the private sector, we cannot afford for what happened to this patient with an inconclusive result, because the patient is paying for everything. And therefore, all our biopsies are guided. I know it's a different situation, but if we could move towards guided biopsies by the surgeons, if you've got an ultrasound machine that's available to you, and do an ultrasound guided biopsy, this lump is actually quite large. And I think the problem with your situation is that sometimes what is happening is it's the medical officer or somebody junior, even the houseman, that is doing the biopsy and not competent enough to do a proper biopsy, even on such a large lump. It's also the size of the needle that you use for the core biopsy. We say a minimum of 5 passes. You've got to get 5 good specimens that sink in the formalin. He can't be floating on top of the formalin, then you know it's not a good specimen. So these are the small things that need to be emphasized if you're doing freehand biopsy.
Yeah, totally agree about that. So I think even one good biopsy is better than 5 floating specimens. Okay, all right, we shall move on. Ms. Rubiah, I think the next slide, you would like to share more about this patient?
Yes, okay, very good points. And yeah, we should have some workshop or something for new MOs. Okay, okay. So this is the counseling upon reviewing the day of reviewing the mammogram and also the true cut biopsy results. So counsel to patient regarding the option of repeat biopsy, the pro and the cons, the possible delay of diagnosis, because we need, again, I'm telling, because we don't have in-house histopathology, so the sampling will be sent out again to the hospital Sadar. So again, we'll go another flow of 2 weeks waiting for the HP to come back. And we also did touch on the diagnostic excision. This part mainly because we are still not sure whether patient can still engage to our follow-up or he might run away, because now the diagnosis is still uncertain. So we just open the discussion about diagnostic excision, whereby wide local excision, whereby we are taking another a wider margin excision. Perhaps if it come back as malignant, she would get another second surgery without touching the breast. Needing of second surgery for the auxiliary procedure if the HPE came back as malignant, also explained. So patient came during this time, was alone. The husband was not around, so she's appeared undecisive and request a 1 week period to discuss with the husband. So the discussion here is by medical officer and a surgeon. Since patient was not give any decision, so the appointment was given for the next following breast clinic lah. So 1 week later, the counseling. So this time the counseling happened only from the documentation, only by medical officer without any surgeon around. I'm not sure whether any surgeon around, but from the documentation is none. So upon counseling with the patient and spouse, so somehow the patient and spouse agreed for wide local excision. I guess because they don't want another delay, another painful, go through another true cut biopsy and they wait for the 2 weeks. But somehow, I would say this is outlier from our usual practice. The surgery date, even so, the explanation regarding the suspicious lump, the suspicious mammogram and ultrasound, the surgery was given 3 months later. All right. So, I would just comment the documentation was relatively poor, and this medical officer is actually I would not pointing towards a personal problem, probably a little bit some systemic issue as well. But this personnel is actually attachment family medicine medical officer that attached to our department for 1 month. I'm not sure what was the discussion with the surgeon previously, but all the decision made by himself, signed and chopped by himself, and clearly this is a deviate from our standard management, whereby for all suspicious lump, we would give a surgery date within 2 weeks of decision day. Any comment from the floor?
This was not made to known by the surgeon until the day of admission.
Yes. Okay. Yes. So that's why I think there is probably little bit weakness on the system here. But the moment the decision has been made, patient was referred to NS clinic. So patient goes into that flow, all right, and no safe net in between until she admitted on August.
I think we can open the floor to
Yeah.
all the panelists on how do we tackle those attachment students as well as trainees, and how do we get the message across? I mean, we have a lot of all these echo meetings. Well, not all of them join this meeting, but is there any way that we can actually educate them more effectively?
I think this problem with some flaws with this attachment trainee for a month, because they are going to be in the department in just a short period. So monitoring can be a bit loose. And but I just wonder that Miss Ruby, because this patient went into the group of I mean they went into the pink ribbon flow, right? So I thought when you have this pink ribbon center, you will follow up on the cases. You have your navigators, right? Kan?
Okay, we are not the conventional pink ribbon center.
The one that
Yes.
we have in Klang
Yes.
hospital.
No, we are not.
Oh,
We
okay.
just
Alright.
we just up to facilitate the diagnosis, but we do follow up our cases, and that's why I said, because that's why this case was seen during the counselling seen by the surgeon, but the subsequent follow up was not documented whether the surgeon was there. Plus, this medical officer is attachment. We suppose all the case that he or she saw must discuss with surgeon before deciding for any, especially doing procedure, putting up for surgery, which is unfortunately missed out on this patient.
And as you said, this is the outlier.
It is definitely outlier, I would say, because from our audit, our timing is within 2 weeks, 7 to 14 days.
Can I just, Rubiah, can I just say that when I was in government service, one of the simple ways we got around doing this sort of situation was that the OT book or the booking, the OT booking was always with the surgeon. So if you want to book a case, even if it's a breast lump, okay, or a excision biopsy or a whatever, anything that's to be done in the OT, the OT book sits with the specialist. Okay, so whatever you want to book, you have to talk to the specialist. So I don't know whether that flow is there. So it's a very simple sort of break point or checkpoint that you can just simply control by holding the OT book. So nobody can, number one, nobody can flood your list. Number two, these sort of things then are able to be cut down on. You don't get massive delays like this when you know that, because they've got to come and present to you why they want to do this surgery. And if you are holding the book, then nobody gets in unless you say so. So it's quite simple that way. The other way, of course, would be to audit your cases every month. You look at your histopathologies that have come back, and even though they are not so that they don't slip through the gaps, so you just audit all the histopathologies that have been done for that month. Again, everything gets signed. All the histopathologies must be countersigned by a surgeon. That means ultimately the vicarious liability is with you. It doesn't matter who your MO is or where they came from. If the patient sues, it's you and your neck on the block, on the chopping block. So it's very good to audit all your histopathologies for that month. You have one day where you take everything for the month and look at them and then ask, what happened to this one? What happened to this one? And then it sort of decreases the number of patients that fall through the gaps.
So one of the suggestions.
Yes, Prof. Rima.
So one of the suggestions that we also got from our own patient navigators was that every month the new patient list has to be audited to see if they're following these timelines that we had earmarked. And if one of them is falling short or one of them is getting delayed, Then the patient navigators, and in your case, if you don't have navigators, maybe one of the specialized nurses can take this job up and call these patients up to just find out as to whether they are deviating from the decided path on their own, or if they are struggling with some issue and which is why they are not on that path. This is also the time where, like Dr. Patricia said, is that you review your histopathologies and try and figure out if something is an outlier where your suspicion was fairly high, but right path correlation is not happening. So perhaps having a checkpoint or an audit is essential, even for smaller hospitals.
Yeah, I think Rubiah, I think I have to congratulate Rubiah because she, working in a general hospital, they do everything. They don't have just focus on breast or something like that. But I think what you have now, you have started something, the Pink Ribbon Center. Maybe what you need is some structural support because surgeons will be running here and there. So you probably need, maybe a medical officer who's dedicated to the service that really looks at all the data and then monitors it every month. Because I have to say, when you work in a large hospital with different team members, different surgeons, sometimes it's very difficult. But if you have, I'm actually quite jealous of the Tata Memorial Center, KBAT, the patient navigator service that they have. It's a very strong structural support actually for the audits and to make sure people get through the system. So, Rubiah, you can, I'm sure there are many places in Selangor, like in Klang, they have a dedicated medicine that runs the Pink Ribbon Center. So maybe, using this case study, you can bring it up to your director of the hospital, maybe this is what you need to actually run a good service, to have a dedicated medical officer and maybe, an admin officer to focus, and it's not just for breast cancer, it could be for colorectal cancer, could be for thyroid cancer. So I think these are the things that sometimes we are surgeons, sometimes we go into this tunnel vision, then we try to sort out things on our own, but actually we can ask for help. But I'm really jealous about the Tata Memorial Center KBAT system. I think Anita, we were both there. We hope that we can collaborate further, Rima, on that project to see how we can bring structural support for our teams back here in Malaysia.
It's 9 o'clock.
We've gone through a whole lot of teething problems also in the navigation program, but now it definitely is a very strong platform for a whole lot of mundane things that we used to struggle with. So I completely agree with you. Having some sort of navigator or nursing support or some structural support, it could be a secretarial support, so long as it's a dedicated support and not just a medical officer who comes in for 1 month and messes things up as compared to as against helping you out.
Yeah, I think this particularly sums up the importance of actually handing over and also the audit. Yeah, okay. Right. So, Rubiah, do you want to carry on?
All right. So we carry on. Okay. So now August came. So she came to the ward electively for the scheduled ward local excision. So it's not a surprise. The lump now increasing in size with some nipple changes and slight pudorunge. So clinically, the lump is still mobile, but measures now 10 times 10 centimeter with palpable ipsilateral axillary lymph nodes. There's no symptom and signs of distal metastasis. So in short, the local disease was now locally progressed. Due to the delay of tissue diagnosis and the mismanagement. So I'm opening the floor to discuss on the management in large tumor. So now clinically is T4B. So the options and we are still favoring around mingling around the issues of anticipating default management if we subject patient for neoadjuvant therapy, since she needs to go to other center and frequent follow-up before deciding for the surgery to remove the local disease.
Yeah, so I think due to time constraint, maybe Rubiah, you can just
just finish off this slide.
yeah, just finish.
Okay. So we recounsel the patient and we repeat the biopsy. Also this time around, because the tumor is big, so we did a freehand to-cut biopsy and explain regarding the need of neoadjuvant therapy. So the to-cut biopsy done on 15th of August, and we get the staging CT scheduled on 6 September. We review in the clinic on the 23rd August. This time around, the CT yet to be done, but the HPE came back as invasive carcinoma, ER/PR positive, HER2 negative. So this is so eventually patient subjected for neoadjuvant therapy and referred to IKN. Since this patient is married to a Malaysian, so she received the referral was received to IKN. We had an experience before, a patient foreigner, the spouse also foreigner, the neoadjuvant therapy we goes to HKL rather than AKN. So probably we reserve the comment and or the input from IKN later. So the issues slightly delay in the arrangement of staging CT. I was thinking whether there's a delay in the oncology referral, but from my workup, it's just within a time limit. She get the appointment within a month, and she had a so far good compliance to our follow-up. So we give appointment estimated around third cycle, but eventually mixed out with some her other appointment in IKN. So in fact, we saw her at the 5th cycle of the FECT for the reassessment. Clinically, it showed partial response, which is the lump now regressed to 5 × 5 centimeter with some nipple distortion. The axillary node this time is not palpable anymore. So at this time, we set up the tentative mastectomy and AC given date of 10 February, estimating this was at the third week after the 6th cycle of chemotherapy. And we give another SOPD review so that she is fit for the surgery on 26 January 2023. So I'm highlighting the importance of reassessment to assess the response of neoadjuvant therapy and to get a decision of surgery and pre-operative arrangement as outpatient. So February 2023, she clearance done. It was uneventful. Some seroma recollection, which is we aspirated twice. The HPE come back as YPT3 and 3 with a 15 positive lymph nodes, M0 ER/PR positive, HER2 negative. She completed radiotherapy 15 fraction, just ended last 18 May. And we just saw her on 18 May. She's doing fine. So due for surveillance mammogram soon. So what we learned from this case, we need to improve our local system. As other panels highlight, we should audit our system, our PRC, and our histopathology picked up from our to-cut biopsy. And we need to continuously spread the awareness, especially to the new staff, new medical officer joining the department. I guess this is importance of a multidisciplinary team discussion with oncology, with the pathology in special cases that require subspecialty attention. So that's all from me. I shall stop my sharing.
So thank you very much, Ms. Rubiah, for the good presentation. And we actually can learn a lot about all the delays that we observe in this case. So the next 15 minutes, we're going to spend on any questions from the panelists as well as from the audience itself. So please feel free to type in your questions in the chat box, or you can actually question directly in this chat room. So before we call for the Q&A session, maybe let's get some feedback from Dr. Rizma, since she's the oncologist from IKN and actively managing this patient. So would you do differently to this patient? Or what's your take on this case in terms of the neoadjuvant treatment?
Okay, hi. Thank you, Ms. Rubiah. Okay, it's a very good case, and I would say this is quite a common situation that we face every day in our daily life. Okay, I got a few points here. I think from oncology point of view, we will start to interfere when the patient needs a neoadjuvant therapy. And like Prof. Rima emphasized, we try not to delay in initiation of is either neoadjuvant or adjuvant. So what we can do for this patient, personally, this patient, if we discuss the case in MDT prior to the referral for neoadjuvant, then it's good that both oncology and surgical team are aware, and we can give an early date to see the patient. Other than that, I think when we discuss the case in MDT, perhaps we can establish the financial status. Usually IKN, we will straight away ask if it's a foreigner, whether is it married to Malaysian or not, because it's make a lot of changes for us. We accept those foreigner who married to Malaysian. I noticed just now Ms. Rubiah brought out the issue about the foreigner. It's an issue, actually it's not with the oncology, it's issue with our unit hasil. Yeah, in terms of the payment, and also usually foreigner who is not married to Malaysian, we will ask to get help from our colleague nearest oncology center, which is Hospital Kuala Lumpur. Okay, and other than that, of course, we want to start the chemotherapy as soon as possible. So other thing that we can do, this patient, perhaps primary team can have a look at the, for example, venous access. It's a very small thing, but if we can predict that the venous access is difficult, maybe we can, primary team can arrange early chemo insertion while waiting for oncology date and also initiation of the chemotherapy. I think it's a small thing, but it's play, a big role. Another thing is this patient also is a young patient, childbearing age. So when we discuss the case in MDT, when we confirm we're going to give a chemotherapy, at least we can refer patient early to the contraception clinic, so that patient can be mentally and physically prepared. When they come to us, we can straight away, try our best not to delay in initiation of the chemotherapy. And other thing, when we start the chemotherapy, is an oncology team that need to very proactive in terms of monitor the response, and to refer back to the surgical team at the end of the chemo, preferably around after cycle 4 or cycle 5, so that the surgical team have a good time to reassess and prepare for the operation. We try to avoid refer to after cycle 6 or clinically not really good response, but when we send back to the surgical team, and then we have to start all over again. Surgical team said cannot operate, so we have to start all over again, start another regime, chemo and all. So I think all these things play a big role in order for us not to delay initiation of the treatment. And other thing, I just want to add, after the op also, the referral refer back to the onco team for the adjuvant therapy also very important. And perhaps if surgical team can, try to refer patient to the early physiotherapy, so that if we always encounter patient, we cannot proceed with radiotherapy because the limited movement of the shoulder, for example, or because of the surgical side complications, seroma and all. And my last point is, if surgical team got problem post-op, can always communicate with oncologists. Sometimes if we cannot proceed with radiotherapy or chemotherapy, if patient haven't got any neoadjuvant, at least we can start hormonal therapy first if it's positive, while we settling all the infection, radiotherapy for physiotherapy and all. So I think if we discuss the case in MDT and then we always communicate if before or after operation, it will be very helpful in order for us not to try to delay and fasten all the process in every level.
Yeah, thanks, Dr. Rizma. Do you find it difficult to send the patient back to another hospital, knowing that IKN and Kajang is quite far away just for assessment of operability?
Not really.
Not really. Okay.
Not really, because usually we will refer back after cycle 4, and then they will have sometimes cycle 5, cycle 6. Usually not an issue. Not an issue.
All right. Okay. I think in the chat box, Dr. Zawin mentioned that we should actually have an MDT with the radiologist, especially when there's a diagnostic dilemma. Maybe over to you, Dr. Mezlina, or what's your take on this? Do you think having a MDT probably online like this would be helpful, or do you think need to meet up in person?
Okay. For this case, I think for the first part, I would like to encourage to do imaging first prior to the biopsy. Okay, so if possible, just do the imaging first. So in this case, the first time, the true cut biopsy done prior to the mammogram, and then the second true cut also not done under imaging guided. So it's not necessary to have MDT, but just to have discussion with the radiologist whether we can help out, whether we can do the image guided biopsy, which is more accurate rather than freehand true cut. Okay.
I suppose I think I hear very important points actually. I think listening from Dr. Rizma, Dr. Mezlina about how MDT may be very helpful. So can I ask does the inter-hospital MDT occur? Does it happen at the moment, or is just intra-hospital at the moment? Does it cut across different hospitals at the moment for service?
I think I will answer this for our local area. I mean, I can't comment on Kajang Hospital surgical fraternity, but for us, we have IKN and the HPJ team as a group of physicians that manage breast cancer will sit together. But it's basically we discuss on complicated, difficult decision making cases. So we don't actually have MDT at the beginning of our encounter with the patient. So if let's say the primary team we want an early diagnosis, so if we need an ultrasound guidance first service, then we'll get our radiologist to do it, or we can even do it in our own clinic. So, and even our MDT with IKN team is it's multi what to say, it's not just breast cancer cases. Yeah, it's multiple. It includes endocrine or even colorectal cases that if we need to. So no specific breast cancer so-called MDT for all cases. Yeah.
Sorry. Actually, I'm quite
Hi,
impressed that. Hi, Vaish. Sorry, you want to say something? I'll keep quiet.
No, sorry, sir. Do we have just 2 minutes or something? Are we running short of time? Just a quick one. Yeah, I think I was listening to the whole topic and I think the scenario that was presented is actually a very, very, very common situation that we see, I think, on almost a daily basis. I don't think it's anything specific to the center that presented, because it's a national problem in Ministry of Health hospitals. So having said that, moving forward, I believe that for everything, there must be something good that comes out of it. And there must be measures which are implemented. And only then I think there is some justice to the patient, at least. So moving forward, this whole idea of MDTs, I think many of us come from a background where we believe that every oncology patient must go through an MDT in the ideal situation. Of course, if we step into any established oncology center, there is nobody who will touch a patient without an MDT. So whether it is the surgeon, the oncologist, the pathologist, the radiologist, whatsoever, there is almost never anyone who makes a decision as a sole person. It always has to be a combined approach. So moving forward, with regards to the CCAN project, actually we have initiated talks with the head of oncology services, Dr. Rose, head of IKN, Dr. Rose Susanna, head of surgical, Dr. Anita, and we actually went through quite a bit of discussion with trying to make these MDTs as mandatory. So starting first with the so-called Greater Petaling areas, so we actually really actually more on a personal approach, really trying to force it down, because I think this is long overdue, very, very long overdue. So for IKN side, it's mainly for Kajang, Serdang, as well as, of course, Hospital Putrajaya is established, but Kajang, Serdang, and the other one is, what's the other one? There's one more hospital which is within the Greater Petaling. Sorry? No, there's one more, Serdang, Kajang, and can't recall which one. Klang Shah Alam, which are huge breast centers, but with no MDTs going on. And for HKL side, we have started Selayang now. We are moving on to Ampang soon and trying to get Sungai Buloh on board as well. So I really believe if we really want to make a difference here, we really need to push forward with these MDTs. So I would like to ask and appeal on behalf of the MDT committee for this weekend. Dr. Anita is very supportive. We have approached Dr. Sadhana and Dr. Rose. So Rizma, from your side in IKN, if we can get support from the oncologist there to commit time and energy and to make these MDTs as a 2-weekly basis, to get all the breast cases to be discussed, even if it's as brief as ever. But I truly believe slowly it will really fine-tune things with regards to pathology, radiology, even getting nuclear medicine on board. IKN has got a PET-CT. You know, there's so many approaches which are available, getting geneticists in, getting the social workers, all that can slowly, start if we commit towards a commitment to have a regular MDT for all these centers. So the next National Oncology Committee Service meeting is on the 7th of June. I'm hoping that by that meeting, we will have a definitive decision, because I think procrastination goes nowhere. So hoping that all members of the floor here will be able to put our foots down and say, yes, this is what we will do. And for all the patients whom we think we didn't manage properly, this will be justice to them, that we will take action and we will make a change. So thank you, everyone.
Thanks. Yeah, I think it really makes a difference, even in the private sector. In a couple of years ago, nobody does tumor board or MDT, zero. Okay. But, we insisted and insisted. And in private sector, it's very easy. You provide breakfast, everybody comes, so some incentive into getting it moving. Okay. Even in your own hospital. Okay. Even if you just have to pick up the phone or get on a phone call with the oncologist, they're always difficult to pin down. Your radiologist and your oncologist, for the surgeons, they must be your best friends. If you haven't married them, then you might have to arrange some situation where, that's it. You can pick up the phone and speak to them and get something done, not yesterday, but today. That's the sort of relationship you must have with your radiologist and your oncologist. Okay, the pathologist.
The thing that,
the pathologist will always be there for you, so no problem.
So you see, when we discussed just now, what is missing really is that structural support. The person, administrative staff that will actually send those emails out, the ones that you can pass the list of patients to, and who will do it by clockwork. It doesn't depend on an MO, doesn't depend on a surgeon, doesn't depend on anyone, but there is a system. So Vaish, I think it would be wonderful when you start this, but I think you all need support, because like even for us in UM, I think the only reason why we have these MDTs by hook or by crook is because Intan, our staff, has sent out the email and everybody knows there's something going on at lunchtime. So it's like you have no choice. You just have to attend it if it's your turn, So if you have something structural, I think it will be more sustainable. So this is the time you can minta staff lah, kan? So
Even when I was in GH, it was our breast care nurse that organized the MDTs every week. We used to have one every week. Insisting that, are you coming? Are you coming? Are you coming? Then of course the doctors have to turn up. So I think if you have just one particular person, you say, okay, this is your job description, and usually the breast care nurses do it excellently, and or one of your admin staff, and then get it going. You have to have a team leader.
Let's ask Nadia lah. Mitra Nadia bahagian lean management kan. So there are many avenues to get support, right? So Mitran, any comments?
Yeah, kalau talking about Assalamualaikum, anyhow, saya Mitra Nadia from my background is oncology nurse, but now I'm at Institute of Health Management dekat NNIH. So right now memang all the things that we are managing is about helping the hospital, the facility in KKM doing the lean to improve their services. So we ever face all this problem banyak lah, either hiccups or whatever frost like this, So the most important thing is for you, how Dr. Rubiah just now has kupas all your problems. you have come up with the RCA and the things can. So the thing is, how you want to overcome that, you know about the flaws that, maybe the multidiscipline, the communications was not right, or etc. So, and then the strategy that internally your team or multidiscipline in your hospital, what to do. So we have come up with the MDT as well, in which existed some in the other hospitals, in which can be practiced here in your area or few of the hospitals connected to you, and also what's inside the entity, especially the human resource, as we said, the gazetted person, the expert, the nurse, or anybody that can organize it. Even the nurse itself, when I was in hospital before we went to do MDT, but I never go into the breast MDT, but last time in gynae onco, we used to call the patient, you see, for the pre-op assessment, all that kind. So when we call the patient, sometimes we just ask, okay or not, but they will tell us some of their problem as well. So the nurse shall bring all this problem or whatever the patients tell you, beside the organizing, to be shared in the meeting, in the discussion. So there will be extra input, for the patient. And also later on, that information from either the MDT or the discussion, you are the one, the nurse is always will go back to the patient and inform the patient, because the attachment, the patient and the nurse normally more than the doctor, because the way of they're approaching to know what the doctor say and all that, the nurse will be closer to the patient. That's my experience lah.
Right.
Also regards to the billing also is I've put in the chat box. I agree that last time I faced, if the patient is married to the local, we could help them, but the problem is they are not, you see. So sometimes my doctor used to talk to them, either they want to go back to their own country and get treatment done. Earlier, we will give a letter, we will give everything, the x-ray of anything, something like that.
Yeah,
That's
I think today is a wonderful discussion with in regards to the delay and the treatment interval. So I think we are at the end of our agenda today, but before we close the session, maybe just a few last words from Prof. Rima. I think she mentioned that I can't actually see her online, but she did mention that it's important to value the opinion of all those who participate. Oh, hi, Prof. Rima, you're back. I can't see you.
So I just wanted to say that we all are having a good discussion regarding the importance of MDT, and I'm certain that a lot of you are highly motivated in trying to establish the MDT culture in the greater Petaling area. So one thing I would like to say is that there are certain points I had made, and both I have put in the chat box. One is that initially it's of inertia, and you will have the nurse call each of them up and remind them, send timely reminders saying that there is an MDT today and there are these cases, please join. And sometimes even right before the MDT, calling them and asking them to come back to the MDT is going to happen. But subsequently, if the participants' opinions are valued, and if they find value in coming to an MDT discussion, if they also learn through the process or things get expedited, then a whole lot of them would want to come subsequently on their own, rather than having to push them to try and come for the MDT. And again, having just small things like breakfast or having just a sandwich or something can be attractive. However, it can be, managed. So those things are important. And these things, what we also experience is that not just patient management, but also the camaraderie between the oncologists, the comfort factor between two oncologists improves a whole lot once they sit together on the same table and talk to each other.
Yeah, sure. Thank you very much. I think the keyword to take home today is the word commitment. All right. Okay. Commitment for our patient. So thank you very much again once and for all the panelists, as well as Prof. Rima yourself, and also to our dear audience. And we hope to see you again in the next session, probably in 1 or 2 months' time. Please join us for the next series then. Okay. Have a good night.